next speaker will be our brilliant star, Dr. wadha Jasser. Dr. Wadha is a gastroenterology and hepatology consultant and an advanced therapeutic endoscopist at the Senyan Ghanem Gastroenterology Center at the Amiri Hospital. She completed the internal medicine residency in George Washington University Hospital, gastroenterology and hepatology fellowship at Georgetown University Hospital, as well as her advanced endoscopy fellowship at Georgetown University Hospital. Dr. Wadha will speak about diagnosis and the management of Barrett esophagus, where we stand.
All right. So thank you for the introduction. Good morning, everyone. Thank you for being here. It's my absolute pleasure to be discussing perhaps a topic that's not often discussed in our region, but we're seeing more and more in the last few years, which is Barrett's esophagus. So today we're going to be talking about the diagnosis and management of Barrett's esophagus. Where do we stand today? So I have no disclosures. Today we're going to be discussing standardized methods for quality endoscopic evaluation of Barrett's esophagus and how to incorporate current clinical guidelines into your practice for screening and surveillance of Barrett's esophagus, as well as learn about new methods for screening of Barrett's esophagus and detection of dysplasia, and understand, most importantly, how we can treat Barrett's esophagus. So by definition, as you all know, Barrett's esophagus is a metaplastic change of the distal esophagus, where the normal squamous epithelium is replaced by specialized columnar epithelium with goblet cells. So it's associated with, as you know, chronic GERD. Up to 10% of patients with chronic GERD will harbor Barrett's esophagus, and it's present in 1 to 2% of the general population. So Barrett's esophagus is actually the only known precursor to esophageal adenocarcinoma, and therefore this makes the detection and diagnosis, an accurate diagnosis of Barrett's esophagus, extremely important. So if you look at the recent guidelines from the ACG, the suggestion is that the diagnosis of Barrett's esophagus not only requires the finding of columnar and goblet cells, but also intestinal metaplasia. So this is extremely important because this differs maybe perhaps from the other guidelines. They also suggest that the columnar mucosa should be at least 1 centimeter in length, and that we should not be biopsying normal or irregular Z-lines. Again, a very important thing that's, I think, often missed in our clinical practice. So as you know, the distribution of goblet cells within a segment of Barrett's esophagus can sometimes be patchy, or is often patchy. And this is the reason for sampling error, which makes or leads to false negative measurements or diagnosis of Barrett's esophagus and intestinal metaplasia. Therefore, the recommendation is to obtain 8 endoscopic biopsies in order to diagnose metaplasia or Barrett's esophagus. And if we do obtain 8 biopsies, this actually increases the diagnostic yield up to 94% of intestinal metaplasia in our biopsies. It's important to note that any dysplasia that's detected, whether low-grade or high-grade dysplasia in Barrett's esophagus, should be confirmed with a second expert or GI pathologist because of great inter-observer variability. So who should we screen? Just to give you a little bit of perspective, screening programs for Barrett's esophagus have been limited, and there is actually a lack of data to suggest that it has an impact on the incidence of esophageal adenocarcinoma and esophageal adenocarcinoma-related mortality. Actually, less than 10% of patients with esophageal adenocarcinoma had a prior or have a prior diagnosis of Barrett's esophagus, and 40% of patients with esophageal adenocarcinoma have no history of GERD. So do we need to screen patients? There is currently insufficient evidence to support the effectiveness of screening programs. However, if we were to perform screening, we should identify or stratify patients into high-risk and moderate-risk patients. So who are the high-risk patients? High-risk patients are those with a family history of first-degree family history of esophageal adenocarcinoma or Barrett's esophagus, and the moderate-risk group are those with chronic GERD symptoms and 3 or more additional risk factors for Barrett's esophagus. So those include male sex, age above the 50, white race, smoking, obesity, as well as a family history of Barrett's esophagus. So are there ways to screen for Barrett's esophagus other than doing an endoscopy? And the answer to that question is yes. So there is less invasive methods for screening. There are multiple devices in the market, but the greatest experience today and the largest evidence that we have is with the Cytosponge device. So the Cytosponge device is a capsule that's swallowed orally and then withdrawn, and on withdrawal it basically obtains esophageal cytology samples, and those are tested for biomarkers that are associated with Barrett's esophagus. So you can see the Cytosponge device here. Obviously it's very easy because it can be performed in the outpatient setting. Even your nurse can perform it in your office or in your clinic, and it requires no sedation. So the biomarker that's being tested is the trefoil factor 3, which differentiates Barrett's esophagus from the gastrocardioid and squamous cells. So you can see that the specificity is quite high, up to 94%, and the sensitivity increases up to 93% if the Barrett segment is more than 2 centimeters. Obviously, this is cost effective because it will reduce the cost up to 30% when you compare this to an upper endoscopy. So why do we need to diagnose Barrett's esophagus and monitor these patients? So I always like to quote these numbers when I talk to my patients or when I first diagnose them with Barrett's esophagus, and I think that reassures them and kind of calms them down and relieves their anxiety a bit. So if you look at the incidence of progression of non-dysplastic Barrett's to low-grade dysplasia, it's a cumulative or an annual incidence of 1% per year, and 0.7% incidence of progression from non-dysplastic Barrett's to high-grade dysplasia. The incidence to esophageal adenocarcinoma is only about 0.2% per year. So I think it's low, and I think it's useful to quote these numbers to your patients when you first diagnose them with Barrett's to kind of just, relieve their anxiety a bit and let them know that the risk of progression is very low. But having said that, it's important to monitor and enroll them in a surveillance program. So indefinite for dysplasia is a common finding that we see in biopsies of Barrett's esophagus. It's found in up to 4 to 8% of these biopsies. It's a finding where the pathologist is basically unable to determine whether these changes are due to underlying inflammation or actually are truly dysplastic. So what we do in this situation is that we have to confirm these findings with a second GI pathologist, and if that's confirmed, we have to place these patients on an intense PPI protocol and then repeat the upper endoscopy within 6 months. So the risk of progression for indefinite for dysplasia is about 1.5% risk of progression to high-grade dysplasia and 11.4% per year to low-grade dysplasia. How about low-grade dysplasia? There is a cumulative incidence of about closer to 1.7% per year to high-grade dysplasia, and obviously high-grade dysplasia has the highest risk of progression, up to 10% per year to esophageal adenocarcinoma. So surveillance actually is effective, and regular surveillance has proven to reduce all-cause mortality from esophageal adenocarcinoma, and patients who were enrolled in a surveillance program were more likely to be diagnosed with early esophageal adenocarcinoma. So this is kind of a summary of Barrett's esophagus diagnosis, kind of to just go over it pretty quickly. So if you see a salmon-colored mucosa on your upper endoscopy, again, if it's less than 1 centimeter, or if it's a regular or an irregular Z-line, you should not be biopsying these Z-lines or these patients. However, if it's more than 1 centimeter, then you have to obtain the 8 samples or follow the Seattle protocol. If intestinal metaplasia is confirmed, and there's no dysplasia, then you stratify those patients into short segment Barrett's or long segment Barrett's. So long, and the cutoff is usually 3 centimeters. So if it's a short segment Barrett's, then the interval or the next surveillance endoscopy is actually in 5 years. So you don't need to be scoping these patients yearly. If it's a long segment Barrett's, more than 3 centimeters, then the repeat or surveillance endoscopy is actually in 3 years. Again, if the biopsies from the Barrett's is indefinite for dysplasia, as I mentioned earlier, we have to confirm that with a second pathologist. If it's confirmed, then put them on an intense PPI regimen and then repeat the endoscopy in 6 months. How about if it's low-grade or high-grade dysplasia? Again, you have to confirm that with a second pathologist, and after you do that, then you enroll them in an eradication program or treatment. How about if the biopsies are actually negative for intestinal metaplasia? Do you just ignore these patients? No, you still have to repeat the endoscopy with biopsies in 1 to 2 years just to make sure that you didn't miss Barrett's esophagus. So these are the surveillance intervals from the ACG. The only thing I want to highlight is that patients with low-grade dysplasia who opt out of eradication treatment or basically endoscopic eradication treatment and opt for endoscopic surveillance should be monitored very closely. So you should repeat their endoscopy 6 months after diagnosis, and then at 12 months, and then annually thereafter. So it's very important to have some quality indicators when we describe Barrett's esophagus. Part of that is our standardized standardized description system, which I'm sure you're all familiar with, the Prague classification. So the Prague classification basically describes the distance or the circumferential extent and the maximum extent of metaplasia from the gastroesophageal junction. So in this lesion, it's described as C2M5. So there are important quality indicators that we must incorporate as part of our clinical practice when we're describing or diagnosing Barrett's esophagus. So obviously you have to identify your hallmarks, the top of the gastric folds, the GE junction, the squamocolumnar junction. You can use a cap to allow for better identification. You can use white light endoscopy, or it's recommended that you use white light endoscopy, high definition, Prague classification to describe the Barrett's esophagus, and use the Paris classification if you see any visible lesions, as well as use the Seattle protocol when you're taking your biopsies. So the Seattle protocol was first described in 1993. It's essentially 4-quadrant biopsies using jumbo forceps that you take from every 1 to 2 centimeter segment from the top of the gastric fold to the squamocolumnar junction. So actually, if you look at it, the worldwide adherence is pretty low. It's only up to 50%. So I think we need to do a better job in terms of applying the Seattle protocol when we're biopsying for Barrett's esophagus. What about Watts? So the ASGE actually recommends that we use Watts, which is wide area transepithelial tissue sampling. This is a stiff brush that's used endoscopically, and the idea is that it allows for greater or deeper tissue sampling and greater surface area and preserves the 3D architecture of the cells and increases our diagnostic yield. So that combined with the Seattle protocol and white light endoscopy, according to the ASGE, should, if available, should be applied to our practice. So we've diagnosed Barrett's esophagus. We have diagnosed either low-grade or high-grade dysplasia. It's important to start patients on eradication therapy. So the most important thing is that if you see any visible lesion within a tongue or a segment of Barrett's, the first thing that you must do is resect the visible lesion. So always resect the lesion through EMR or less likely ESD, and that should be followed by ablation of the remaining segment. So EMR over EUS, usually EUS is not preferred in these lesions as it cannot distinguish submucosal from submucosal invasion, and most of these lesions can be actually resected by EMR rather than ESD. Only specific types of lesions like large lesions or lesions with a depressed center or Paris 2C classification are those where you might consider doing ESD over EMR. Obviously those who have failed EMR, you can also revert to ESD. The goal of eradication therapy is always complete eradication of intestinal metaplasia. So the basic premise for endoscopic eradication therapy is that patients with high-grade dysplasia and intramucosal carcinoma have a very low risk of lymph node invasion. So in high-grade dysplasia, it's essentially 0, and in intramucosal carcinoma, it's around 2%. So studies have shown that endoscopic eradication therapy and esophagectomy actually have no difference in terms of survival at 1, 3, and 5 years. So what are the methods of ablation or eradication that are available to us? So radiofrequency ablation, RFA, that I'm sure everyone is familiar with here, has the highest quality and most extensive evidence available from RCTs supporting its use. It's essentially a thermal modality where you apply circumferentially directly in the esophagus to create thermal injury. So the U.S. National Registry for RFA for Barrett's esophagus with low-grade dysplasia showed a cumulative incidence of adenocarcinoma after complete eradication of intestinal metaplasia to be 1.3% at 5 years. So that's quite low, and all studies have shown that it's, RFA as a modality is quite effective at 12 years for both low-grade and high-grade dysplasia. And most importantly, durability. So if you look at the 5-year data of dysplasia or patients who are free of intestinal metaplasia, it's up to 90%. So in terms of safety, it's pretty safe. I think the main thing that we tell patients is the risk of strictures post-RFA, and it can be up to 5%, but that can most of the time be easily managed with PPIs and endoscopic dilatation. What about cryotherapy? So cryotherapy was developed in 2005, and it's essentially the kind of the opposite of RFA, where you get cycles of rapid cooling and thawing, and it causes cell membrane destruction and ischemia. So there are multiple devices available for cryo. The one that's most commonly used is the cryo balloon. There is less chest pain that's reported in patients post-cryo when you compare it to RFA. Having said that, cryotherapy should only be used as a rescue therapy or in patients who have failed RFA. So it's still not a primary modality for Barrett's. What about EMR? So obviously, if you see a visible lesion, it's always better to resect the lesion completely. EMR serves both a diagnostic and a therapeutic purpose, and it allows us to assess for the depth of lymphovascular invasion and allows us to assess the degree of differentiation as well as the presence of lymphovascular invasion. So you can use either a cap-assisted EMR or a band EMR. So the goal of endoscopic therapy is always complete eradication of intestinal metaplasia. Endoscopic therapy is a standard of care for the treatment of dysplasia in Barrett's esophagus. And EMR is safe and effective to treat any visible lesions, followed by ablation, mainly RFA, which is the mainstay of treatment for both high-grade and low-grade dysplasia, with cryotherapy being used as rescue or as an adjunct in patients who don't respond. So it's important to keep monitoring these patients and enroll them in a surveillance program. And the reason is a third of patients who achieve complete eradication of intestinal metaplasia will have recurrence of Barrett's esophagus. So in terms of a surveillance protocol in patients with a low-grade dysplasia, after you've achieved complete eradication, it's important to take a look and scope them after a year, and then after 3 years, and then every 2 years after that. How about high-grade dysplasia? The same guidelines apply for high-grade dysplasia as well as intramucosal carcinoma. So these patients should be scoped 3 months after complete eradication, and then 6 months, 12 months, and then annually thereafter. I'll end on this note, which is it's very important to obtain your surveillance biopsies post-eradication. I think this is a step that's often missed, and most of the time, what you need to do is obtain 4-quadrant biopsies from the high cardia, which is just below the Z line or the Z line, and then 4-quadrant biopsies from the distal 2 to 3 centimeters of the neosquamous epithelium. And with that, I'll end my talk. Thank you.